I hope we're connected as yet. Okay. We have with us Mr. Henry Hazel, and we have Dr. Reddy, who is a consultant clinical oncologist, and they are representing the Cancer Center Eastern Caribbean, Antigua. Henry, we say good morning to you. And Mr. Henry Hazel is the Chief Operating Officer for the Cancer Center Eastern Caribbean office in Antigua. Henry, good morning to you. And then I know you will introduce the consultant with us this morning as we'll be talking pancreatic cancer. But Henry, maybe in the first 5 minutes, you can give us a little information about the Cancer Center in Antigua. What is its mandate? What are you all treating there, and who is it open to?
Yes. Good morning, Carlton, and good morning to
Uh,
your
yes.
co-hosts as well. It's really good to be back with you, to be sharing with the listening audience of Dominica and further afield, right? Yes, Henry Hazel is the name, as you mentioned, and I'm the Chief Operating Officer here at the Cancer Center Eastern Caribbean. Our center is actually a treatment center for the entire OECS. It was established an OECS mandate. So we treat patients not only in Antigua, but also from Dominica and the rest of the
Mhm.
OECS countries as well too. And of course, we are open to accepting patients from anywhere in the world that people might want to come. But it was important that our leaders decided that we needed to have a radiation treatment facility inside of our region because of the prevalence of the disease, cancer, and our access to modern, state-of-the-art, modes of cancer care. We deem that very important for our people, right? To keep this within a Dominican context, yes, we partner very closely with the local oncologists there at the Dominica China Friendship Hospital. And yes, you do have a chemotherapy capability there on island. And so most, if not all of that gets done there. But whenever there is a need for radiation treatment, then that individual, that patient would have to leave Dominica, and our cancer treatment facility here in Antigua is one of your best options.
Mhm. I can tell you that the testimonies have been very favorable for the center. My sister was a patient there just, I
Mhm.
think, in August, and she really spoke highly of the professionalism and the empathy that was meted to her while being there for 6 weeks.
Mhm.
So, I can say that the testimonies are favorable.
Yes, happy to hear.
Hmm. And we know that cancer itself is very costly. Um, um, but I know that the center, once you're from the OECS, your price is kind of subsidized. Maybe you just want to mention that a bit or elaborate a little on that.
Yes. Well, I think many of us know that treating cancer is a very expensive undertaking. Cancer management is one of the biggest burdens of our governments in our region and our people as well too. Um, uh, we do have a very state-of-the-art care that is available, but our fundamental problem in our islands is that we do not have the budget, we don't have the resources a lot of times, right? Having a regional center was one of the initiatives to sort of assist us towards getting closer to modern care, because we felt that an expensive investment like that could be shared across the populations of the combined territory. Yes, but notwithstanding that, our prices are highly subsidized, but it's still what is expensive and what is not expensive is very relative. But
Mhm.
in our establishment, we establish arrangements with the member countries of the OECS to ensure that the indigent of our populations can have equal access, just as equal as anyone who has money or who have insurance coverage. The indigent as well, it is important that they too have access to cancer care. And our arrangement is that for any patient that will be sponsored by any of our member governments, we have a flat fee of 10,000 US dollars for an entire course of radiation treatment for that particular patient. Now, I need to put 10,000 US dollars in context, right? If you are not sponsored by the government, right, and your insurance is going to be taking care of you, that cost could be in the region of 27 up to 50,000 US dollars for a course of treatment at our center. That also I need to put in context, right? For an equivalent treatment of the range of sites that we treat, if you were to get that done in the United States or the UK or Canada, that price range now goes up to 75 to 150,000 US dollars for a course of radiation treatment. So it's all contextual. There are very less costly options available. For example, patients from our jurisdiction, our region, even Dominica, go to places like Canada and so on. But there is a fundamental difference in the treatment modalities, and we can vouch for the top quality care that we give. It is different, and so the experiences, those determinations would have to be made by the patient. A lot of times, the patients don't know what is the difference between what we do at our cancer center and what is done in a place in South America, right? But we are trying our utmost best to let patients know what is it that they must look out for, right, to ensure that the care that they are receiving is what we call standard of care, meaning it is the best care available on the market and equivalent to what you can get were you to go to one of the centers in the modern in the first world, like the US, the UK, Canada, Australia.
Well, Henry, really want to thank you so much for giving us that at least that preview information as it relates to the treatment options and at least a summary of the cost that is associated with treating of cancer. But we want to switch gears a bit, and I'm hoping that the doctor is there because I think most people really want to learn more about pancreatic cancer. There's been a lot of talk in Dominica about prostate cancer and breast cancer and colorectal cancer, which, and cervical cancer. Those seem to be the most popular ones, and lung cancer that we're seeing in Dominica. But pancreatic cancer, we're not hearing much about it as such in Dominica. Not that people may not have battled it and some people may have died, but we've not been hearing much about it. From the research that I've done, I mean, pancreatic cancer has always been kind of characterized as the world's deadliest cancer, merely because of its location and the diagnostic, the difficulty in diagnosing that particular cancer. And even when I looked up the 10 most deadliest cancers in the United States, pancreatic cancer was number 4. Lung cancer actually is number 1. Pancreatic cancer is number 4. Dr. Reddy, if I may abbreviate your name and call you Dr. Reddy, are you on with us this morning?
Yes. Hi. Morning.
Good.
This is Dr. Vaishnavi from the Cancer Center. I am currently a clinical oncologist over here, and we mostly deal with the solid malignancies of all adult and pediatric patients.
Thank you so much for joining us this morning. Doctor, we want to begin by asking what is the pancreas? Because people may have heard of the term and may not even know much about that particular organ and its key function. So if you can start off with the pancreas and its function and so forth.
So, yes. So, usually what happens is pancreas is an organ which is usually located in the abdomen, and it usually secretes enzymes which are which are used for metabolism, to regulatory functions, as well as it also produces insulin.
Mm-hmm.
So
All
yes,
right.
it has both it's exocrine function which helps in the digestion of the food, which helps in turn in metabolism, and as well as endocrine function, which helps in secretion of the insulin and regulation of the blood sugars in the body.
Excellent. Um, this particular cancer, as I said in the beginning, it's very difficult to diagnose. Why is that so?
Yes. So first thing is it's not pancreatic cancer. Yes, it is one of the deadliest cancers, which is related to the currently the third most common cause of cancer-related deaths. But it is not the most common cancer which is usually seen among individuals. So, coming to the Caribbean side, it is like 10th most common cancer which is usually seen. So, when we have a lot of cancers which are in the first priority, like the prostate cancers, the lung or colorectal cancers, we have that more in prevalence in the Caribbean or the United States. So what we do is a screening programs which are usually dedicated to those cancers are higher in numbers, and they get to be screened more often for those cancers rather than the pancreatic cancers because it is less commonly prevalent. And but usually by the time the diagnosis is made, it is usually in the advanced stage, which happens which tampers with the amount of treatment which we could provide to the patient actually. So as it is locally advanced, or if it is spread to elsewhere in the body, then the treatment options kind of limit, and that causes more of the deaths in pancreatic cancer.
But
So the screening is not usual as usually done as it is done for the for the prostate cancers or the breast or cervical cancers. We usually see there are many screening setups which are usually done on a yearly basis, but not for the pancreatic cancer because it is less commonly seen. And there is no definite effective screening tool which had been used, but if there is any family history of pancreatic cancers, or if they are like as they come under high risk, then we usually go for the screening purposes. Not in general, we do not usually screen the for the pancreatic cancers much, which causes more of those deaths.
okay, so we know that the pancreas is the organ responsible for regulating blood sugar levels. Would
Mm-hmm.
you advise, or is it customary, if someone has been newly diagnosed, sorry, with diabetes, that you should look into the pancreas just to check to see whether it's related to pancreatic cancer?
Yes, that is a very good question because in pancreatic cancers, one of the signs which we see is early on, like on new onset of diabetes. Actually, that is one of the signs which we see in the pancreatic cancers. So yes, we can definitely go and have a look at the liver enzymes usually and see if there is any elevation in the liver enzymes or if there is elevation in the bilirubin levels, which would in turn lead us to further investigation. But if the patient is asymptomatic with no family history of pancreatic cancers or breast or any other cancers, and if there is if it is only diabetes, and if providing that other labs are normal, we usually do not go and do further investigations.
Okay.
Doctor, I wanted to ask, Jacinta just asked about early onset of diabetes or onset of diabetes. What other symptoms or what other signs would be present if somebody has pancreatic cancer? Possibly, what is the early sign that an individual would experience if they have pancreatic cancer?
Yes. So the most common symptoms which we would notice are one first thing is jaundice. And the second one is there might be slight tiredness or fatigue, and there would be weight loss. One is new onset of diabetes or worsening of the existing diabetes, and dark colored urine, and pain in the abdomen. And if there is any history of pancreatitis earlier, then that is one of that increases the chances of the patient presenting with the pancreatic cancer in future.
And you're saying all of this, and it brings me back to a story. When I lived on St. Kitts, my landlord, I remember it was on Easter time, she suddenly developed an acute, very violent pain in the stomach. And she went to the doctor. She was given PPIs. She was given, Buscopan and that type of thing. She suffered immensely for maybe 2 weeks. And then subsequently, one of her brothers said, "Why don't you just go to the US?" So she flew to Miami, and she was diagnosed with pancreatic cancer. But I remember the summer before that, she would normally go up to the States every year for her annual checkup, and they diagnosed her with diabetes. And I remember she came home and she said that diabetes is not in their family, and she just was diagnosed with it. But maybe at that time the cancer was already settling there, and had, as you did mention, give rise to the elevation of glucose levels. So and we also know, to doctor, that when a diagnosis of pancreatic cancer is made, because of um, the difficulty in diagnosing, oftentimes when it is detected, it's at a stage 3 or 4. And we know, based on the prognosis, that most people may succumb to pancreatic cancer within 6 months. Um, can you talk a little about the diagnosis of of pancreatic cancer, the stages, and the prognosis associated with those stages?
Sure, definitely not a problem. So coming to the diagnosis, usually we first go ahead with the liver enzymes, the labs actually. So the liver function tests and the blood glucose levels, including the HbA1c and the protein levels, the serum albumin levels. And along with that, there are a couple of tumor markers which we would do along with the blood tests. So, which are carcinoembryonic antigen, which we call as CEA, and the other one being CA19-9. These are the two tumor markers which we usually do for pancreatic cancers. And apart from that, there would be endoscopic ultrasound to see the pancreatic status and if there is any obstruction of the biliary ducts which are present over there. And if there is any obstruction, then they usually go for stenting to relieve that obstruction and to reduce the levels of bilirubin, and in turn reduces the jaundice. So, and apart from that, we do a CT scan, which is called triphasic, and that is usually done for the hepatic and biliary cancers and the pancreatic cancers. So, CT scan of the chest, abdomen, and pelvis with the contrast, and that is usually done to rule out if there is any other metastatic spread as well, along with the primary. And apart from that, we do endoscopic ultrasound guided FNAC or biopsy from the lesion. So these are the most common things which we use for the diagnosis. And apart from this, yes, MRI or MRCP can be used.
Okay. The doctor, if pancreatic cancer is diagnosed, through the mechanisms that you just described, and you have a diagnosis, what is the first course of action for the patient, particularly if it is diagnosed to be, a stage, as Carlton just mentioned, a late stage, 3 or 4? What is what is the first course of action for the patient, or what is said to the patient at that time?
So yes, usually we see even if it is locally advanced, we just check for if there is any spread of the disease elsewhere in the body or not. And if there is a distant, and if it is negative for the distant metastasis, then we usually either go with the chemotherapy first initially to reduce the volume of the disease, and then go with the chemo radiation following that. And if there is any increased bilirubin levels and if there is any obstruction, then we go ahead with the stenting and do the stenting to relieve the obstruction.
Mhm. Mhm. And this particular cancer, it can be very painful. and and most people tend to kind of get wasted, where you lose, you have a lot of body mass reduction, you lose a lot of weight, difficulty in with the digestive system, bloating, pain, discomfort, and all of that. So we would understand that a patient would be on several different medications, almost palliatively, to help with the comfort of the patient.
Yes, the palliative intent is entirely different scenario. Palliative is only used if the patient has any distant metastasis, or if it is really advanced. And yeah, usually in a metastatic setting is when we call it for palliative. Unless until then, we do not usually call the patients as for palliative.
Mm.
And coming to the medications, yes, there would be a lot of medications, because the first thing is they have decreased appetite. Usually, any malignancies, they have like reduced appetite as well as weight loss. But in like in pancreatic cancers, definitely the weight loss is very significant, and usually the patients are emaciated, literally with the muscle, complete muscle loss. Actually, they'll be so thin because of all this enzymatic and the enzyme. There are many digestive enzymes which are secreted by the pancreas, as well as I have already mentioned. So yes, you get to see all that emaciation and everything. But to regain the person's nutritional status, we usually ask them to have a regular healthy food. Even if they are not able to eat it, they'll still have to eat healthy food. And we give something for decreased appetite. We give medications for decreased appetite too, so that the appetite can be improved. And then parenteral nutritional support, we give it through the IV, so that the patient gains some of the weight, or receives nutrients from the fluids which we are giving.
Okay, so
Good moderate treatment.
okay. So, Doc, we're always advocating for preventative measures. And right now, many people are, watching their diets, their lifestyle practices, and ways of improving their health overall. So, what are certain risk factors that one should be aware of that increases the risk of acquiring pancreatic cancer? Is there anything that we have to look out for, or lifestyle practices that increases the risk of this type of cancer?
Yes, the most common risk factors are if the patient has any strong family history of pancreatic cancers, or breast or ovarian cancers, with the first degree or second degree relatives, especially. And apart from that, if the person is smoking excessively, smoking alcohol, and exposure to chemicals or heavy metals like asbestos or pesticides and benzene, all this. And if the person is diabetic, then they should have their sugars well under control with the medications and with the diet, as well as regular physical activity. And then obesity, this is one of the risk factor for developing pancreatic cancers. So if you have any of this, then I would suggest have healthy foods regularly, and then reduce the amount of red meat consumption, go for physical activity regularly, and cut down of alcohol as well as the smoking. So these are one of the preventive measures, I would say. But you should be, if there is any strong family history of pancreatic or breast or ovarian or any other cancers, then I would suggest them to get themselves screened very often, like once in a year at least, get themselves screened.
Doctor, when you say once a year, from what age are we thinking that should happen if the person has a strong family history of pancreatic cancer?
So yes, usually the pancreatic cancer is diagnosed between like 55 to 84 years of age. Most like 74%, 75% of the patients are usually diagnosed in between this age, and only 10% of the people would be developing it if the person is less than 40 years of age. So it
Okay.
is more common among the middle age or the old elderly, and the median age would be 70 years of at the age of diagnosis would be 70. So it's usually seen in the middle and the later stages rather than in the young adults. So it's less commonly seen in the younger individuals. Then that is one of the common cause for the mortality as well, because as age advances, the people are frail. So, and they will tolerate they will not be able to tolerate the complete treatment as well, because of
Mm.
given their
Mhm.
weight loss and decreased appetite and no food, and given their age as well. So we do not usually we will not be able to give chemotherapies to that extent if the person is more than 70 years of age, because they would be really frail.
Mhm.
Okay.
That makes a lot of sense. That
Yes.
makes sense. But in terms of gender, though, is it a cancer that is in which gender do you find that the cancer is more prevalent? Or
No, it equally affects men and women. It's not
Mm,
particular gender specific.
okay.
Amen. But I have a concern. You mentioned about the lines of treatment. Sometimes, when different types of cancers are diagnosed, especially at the later stage, many people choose, as Carlton was mentioning on our previous show, not to undergo chemotherapy,
Mm-hmm.
going with the herbal route of treatment. Is it recommended with pancreatic cancer to follow herbal treatment, or do you advise them, okay, you've reached that stage that going through chemotherapy, radiation at a certain point, it really would not make sense, if I may say so, that palliative care is the better way to go, and just avoid that intensive treatment regimen.
Yes, that is one of the most frequently asked questions, actually, because many people do prefer herbal instead of receiving chemotherapy or intensive treatments. But regarding the herbal treatments, we are not sure to what extent their efficacy is and how would the person or the people respond to that treatment, because we do not have much of extensive studies on that herbal medication. Whereas chemotherapy or surgery or given radiation or any targeted therapy, we do have data to prove how the drug or particular surgery or radiation, like how would it respond and how would it affect the survival of the person. So we usually go for the treatment if there is adequate data, and if there is no data, we cannot compare the efficacy of the treatments if there is no comparable data between the herbal or the allopathic treatments. So as we practice as an allopathic doctor, since we have an evidence we practice evidence based management.
Mm-hmm.
So definitely I would go with the evidence which has been already published and had been in guidelines for the management.
Understandable.
Okay, so what we're going to do, Doc, we're going to take a short break and then we'll be back with you in, let us see, a minute time. So just stay on.
Sure, no problem. Thank you.
Dear Jolly, I need some toys and I heard you got Santa. Pop up in the store and get me what I'm after. Then I heard you got a video campaign. If I say what I want, you'll grant my every wish. Listen, I didn't expect that much this season, but then I heard Jolly's Megaland Christmas Edition. Dear Jollies, I want it all. And you can have it all at Jolly's Pharmacy this Christmas with an in-store pop-up Santa. And all I want for Christmas is video campaign, special offers on selected items, and the first ever Jolly's Megaland Christmas Edition. So this Christmas, put Jolly's Pharmacy on your list because you don't want to miss this. You don't want to miss this Christmas, hey. St. Mary's chips, a chip for every occasion. It's where good things happen. Craving a bite of something tasty but healthy? Then it's time to head to Jolly's Pharmacy and pick up some chips from St. Mary's. Cassava, banana, breadfruit, or plantain chips, the choice is all yours. All ingredients are fresh from the farm and it's healthy. There's zero trans fat, no MSG, and it's gluten free. So when you're making those healthy choices, always choose St. Mary's. St. Mary's, where good things happen. St. Mary's chips, a chip for every occasion, made with love in the Caribbean. Distributed island-wide by Jolly's Pharmacy.
Who say health cannot have vibes? Well, Jolly's Pharmacy is proving you otherwise. With Health Vibes, every Wednesday morning on Q95 from 10 a.m. to 11:30. Health Vibes, education, information, and a bit of humor. And not forgetting lots of vibes. Hosted by Carlton Lango with co-hosts Jacinta Fagan-Defoe and Trudy Kristen. Jolly's Pharmacy is bringing health and vibes together every Wednesday, so be sure to tune in. Health Vibes every Wednesday on Q95 from 10 a.m. to 11:30. Jolly's Pharmacy, leading the way in healthcare.
It is 10:56 Eastern Caribbean time. This morning on Health Vibes, we've been discussing pancreatic cancer, and we've been learning so much. I know that many of you are listening. It's a very popular, maybe the most popular health talk show that is held weekly. And this morning we do have guests from the Cancer Center Eastern Caribbean based in Antigua. And we are discussing pancreatic cancer in the memory of Mr. Anderson Chorley Sr., our former managing director who succumbed to pancreatic cancer. This month, the month of November, is also Pancreatic Cancer Awareness Month. And this morning we have with us clinical consultant oncologist, Dr. Reddy. Dr. Reddy, you back with us?
Yes.
Yes. All right. I know Jacinta, my colleague Jacinta Fagan-Defoe, wanted to ask you a question.
Right. So, with all our discussions, I believe we probably should have mentioned it earlier in our program. But for those who don't know, how exactly does pancreatic cancer form? How does it develop?
Usually, any type of cancers, the cancer cells are usually rapidly proliferating. So what happens is, if it is a normal cell that divides at a particular rate, whereas cancer cells, they definitely have excessive proliferation, which leads to malignant cells. Like, they have genetic mutations. One is the family history, as I have mentioned. If they have already had a history of malignancies, then the genes pass on to the other generations as well. So if they already have those genes, then what happens is the mutations would definitely lead to the malignancies, the cancers.
Recently, Doc, a gentleman called me, and he said that, just like myself, there is a strong family history of cancer. And he wanted to know whether there was a test that, let's say, he could have been put in an MRI machine or something, and to see if there is any cancer cells or any cancer in his body. Is there such a test? Is that available?
MRI is definitely available, but we don't see unless until there is a tumor over there. So that is not a kind of tumor marker, and MRI is not a diagnostic screening tool which is used for pancreatic cancer. Or which particular are you are you talking about a particular cancer, or
No, just talking about cancer. Like, so
In
for
general.
example, there's a strong family history on my end with cancer, and so I just wanted to. So, for example, a person like myself, could I say, well, okay, I want to do a particular test, just to see what my probability looks like?
No, what happens is, if you have a family history of cancers, then what malignancies are those would come into consideration as well when we look for the malignancy. So what family history, like if they have any prostate, or if they have breast cancers or ovarian cancers or colorectal or lung, or what about pancreas this instance. So what depends on what cancers they have, and there's no exactly no, MRI is not the only tool which is used for the screen. MRI is not used for screening. So we see if they have tumor markers, like in case of example for the breast cancers, we have genes called BRCA1 and 2 genes as well. So that is most commonly expressed for breast, ovarian cancers, and even in pancreatic cancers, we can have those mutations. We can see those mutations. So yes, in breast cancers and ovarian cancers, if they have a history of that, then we see that. And we have genetic mutations, like we have specific gene testing, which can be done for particular malignancies to see if they have the genes expressed or not. But MRI is not definitely the screening tool
Okay.
for those mutations,
Mhm.
or to test the probability of or the incidence of cancer.
Yeah. Doctor, what is the prognosis, so to speak, of somebody who has undergone treatment for pancreatic cancer? They've gone through chemotherapy, they've gone through radiation, as you mentioned, the lines of treatment that are available, and they are in remission, or the cancer has been eliminated. What's the prognosis? How does the person live life thereafter? Do they need to continuously check for the reoccurrence of the cancer? So what's the general prognosis like for somebody who has been treated and has has undergone treatment for pancreatic cancer, and the treatment has been to all extents successful?
Okay. So for pancreatic cancers, especially the prognosis of 5 year survival, we call depends on if the disease is localized or if it is regional, or we call distant. So first thing is, if it is local, that means that is only confined to that particular organ and it has not spread to any lymph nodes or any other parts of the body. Whereas regional means it spread from the organ to the surrounding lymph nodes, but not to anywhere else in the body. And whereas distant metastasis means the disease has spread to any other part apart from the primary originating site. So if it is a localized cancer, then the 5 year survival rate is around 29% with the treatment. So, and like if we treat 100 patients, then the 29 patients survive for 5 years is what we see if the disease is localized. And if it is regional spread, then the 5 year survival rate drops to 11%. And if that person has distant spread, then it is 3% with the treatment actually. So even like apart from the pancreatic cancer, whatever cancer we do treatment for, every person should be coming for regular follow-ups to see how the patient is doing in general, as well as imaging or the testing wise. We do follow-ups regularly, like for our first 1 to 2 years, we do it like every 3 monthly, and following that 6 monthly and then yearly basis. So we continue to regularly follow up with the patient to see if he has developed any signs or symptoms, or if he is well or not. And we check his or her labs regularly, and yearly we do an imaging to see if there is any recurrence which we could be seeing. So yes, we definitely do regular follow-ups, and that is needed for any patient if he or she had undergone the management for cancers.
There is this argument, and I maybe I need clarification on it. Where I've heard the talk that every human body has cancer cells. Is that a fact?
They have genes in their body, but they are not mutated, or not every person's genes are mutated. Like they are mutated in the sense they do not, divide in very rapid state actually, or they have any defects in that they do not do the damage to the certain DNA. So yes, we do have the genes in our body, but there are no damage to the the DNA as such. Only if there is any damage to the DNA, that mutation particular gene expresses, and that is how you develop the malignancy. But unless until then, no, the persons do not develop. And if the in pancreatic cancers, if the person do not undergo any treatment, and if they had left, if they had been left untreated or without any radiation or surgery or chemotherapy, then the survival of the person definitely decreases, like significantly. Like it is about around 4 to 8 months, or less than 10 months usually.
Mhm. And doctor, I wanted to
So
ask you, and maybe I'm treading in an area that is, but I wanted to ask you because sometimes, and I remember when another sister of mine was ill with cancer, diagnosed with cancer, and when she was told that her cancer was terminal, she wanted to know how much time that she has. And sometimes doctors estimate based on the physiological and the clinical manifestation, symptoms, and all of that that they're seeing, and all the imagery and tests and so forth. Is this something that is often asked by patients? And is this something that doctors like yourself um, feel comfortable or would normally give an answer to?
uh, yes, we feel very uncomfortable giving that answer because, we want, whenever we see a patient, and if the person is in really good general health or in general condition, then we usually advise for the treatment. But many people, or some people, I would say that they wouldn't want to go ahead with the further management, providing the fears they have in regards to the treatments or the side effects. So many people, some people do drop out actually of going to further management, and they ask us for the duration of the time which they had it has been left. So that usually the duration would depend upon the physical general condition of the patient first thing, and symptomatically we'll have to see how bad the patient is and if there is any obstruction or not, and then to see how in what stage the patient is. So it depends upon many factors, not just in particular just in regards to the certain ones. So we will have to see all the aspects and take them into consideration before we tell them about the survival, expected survival, or the prognosis. But we
Yeah.
usually recommend the patients to go ahead with the treatment and worry less about the side effects, because if they develop side effects, we have medications to manage those side effects, but not for the progression. And when they come to us in very later stages with the palliative intent, then even we feel really bad actually, because we know what patients go through on daily basis. We see them on daily basis.
Mhm.
But that can be a bit tricky because let's say you give an estimated time frame and the person lives months beyond, or even months before that date, that can be very troublesome with the family members and loved ones. So I don't know how you do it or how doctors do it, but
Yes, that is very tricky actually,
yeah.
because we exactly cannot predict the person would be living only for this time period.
Mhm.
So yes, that is definitely a tricky question, because we had many patients who had been having metastatic disease but still on regular follow-ups with some medications, and they had been doing pretty well, but not in pancreatic cancer. Pancreatic cancer is very aggressive, and it would there are high chances of mortality because the nutritional status really depletes,
Mhm.
and the body mass is really go down actually.
Mhm. Mhm. And I think many times people ask. I remember being in that situation with my sister. They ask merely just to let them prepare and do what they have to do. I don't think that they want to know just because they want to give up, but I think sometimes they want to know to prepare if they have to do documents, wills, and all of that. They just want a sort of a guide in terms of how much time that they have for them to prepare these things. I think generally from what I get from people who have been in this situation, that's what they've wanted to know.
Yes, we usually, when we see the person for the first time in the consultation, once the diagnosis is made, we usually sit with the patients and the family, and we explain them regarding the stage of the disease and what is further expected treatment based on the stage and how the patient would be taking it and all the expected side effects. So we will be mentioning and discussing with them in detail, and we will be giving them a few options of how to go ahead, and then they can decide and then get back to us usually.
Okay. All right. I see we have a few callers on the line. Okay, we've missed this one. Callers, please feel free to call if you want to ask the consultant oncologist a question or two. The numbers are 449-3095, 449-3096, 449-3097, 616-4257. And of course, you can call from overseas. Let's take this call. Good morning to you, caller. Thanks for calling.
Blessings to you all.
Good morning to you, sir.
Yeah, bless. I called just because I listened to the lady accent, and knowing if it was from just a Western perspective, I would not have asked that question. Non-communicable diseases, and then you find that some of them are being reversed. I really wonder, because maybe if she's from India or one of those Asian countries, she may be able to testify where people reverse conditions that were non-communicable. And with the pancreas, I heard you mention the pancreas earlier on. Can a damaged pancreas be repaired using what they call alternative remedies? I just wanted a little clarification.
Okay. Doctor, you would have heard the question.
Yes. So yes, in pancreatic cancers, the remedies which we usually provide are, first thing is surgery or the radiation or the chemotherapy. What happens is, in surgery, we usually remove the pancreas and then some part of the duodenum and the other structures surrounding it to reduce the chances of disease coming back actually. So it increases, that's how it increases the survival. It will not definitely restore the complete function of the pancreas if there is surgery done, if the surgery is being done. But in cases of chemotherapy and radiation therapy, no, the pancreatic function wouldn't be restored completely. I wouldn't say that.
And so what you're saying, Doc, that someone can actually live with the absence of the pancreas, but they will
Yes.
have to be using supplementary insulin or
Yes.
What about pancreatic transplant? So
No.
let's say no.
No, they don't do it.
Okay.
I Carlton, I don't know where you were going, but as we were speaking about the giving somebody an estimated time to live if they have been diagnosed with pancreatic cancer, my mind went to, doctor, I know this is not your area, but what is the mental health aspect for a patient receiving news that they have pancreatic cancer, maybe it has metastasized, some news like that. Is there any do you work in collaboration with mental health experts, psychologists, psychiatrists, maybe to recommend the patient to see? Is that something that is done? Because I'm thinking that type of news cannot be easy to deal with, not for the patient and not for his or her family. So what is the approach for mental wellness, if you can comment on that?
Good question.
Okay, so in regards to the mental health, it is not particularly specific about the pancreatic cancer, but cancers in general, I would say. Cancer itself is a disease where people go into depression hearing the name itself.
Yes.
Yes, many people tend to have that. So yes, many people get depressed actually because of the disease. And one of the important thing about this treatments is, apart from the physical health, the mental health of the patient is also equally important for us. So if that is the reason we usually counsel the patients on a regular basis. We see them more often than the person is seen usually in other diseases. We see them on daily basis or a weekly basis on demand actually. So we see them more frequently. We keep continuously counseling them and providing them with that support which they need. And if that is definitely, if it is out of our hands, or if the person is really depressed, yes, we do take the help of the psychiatrist to deal with the situation, so that they can sit together with the patient and the family, so that they could have some moral support from the family as well, or the friends.
Okay.
And that makes a lot of sense because these news can really be, they can really
Yes.
drown you in a sense, particularly unexpectedly. You might be young, you have a lot to live for. You might, have your children. You're thinking of their welfare. You're thinking of what's going to happen to them. You're thinking a lot about the unknown. Cancers generally, when they're diagnosed, are more than likely, oftentimes, seen as a death sentence still. Now, with the advent and advancement of treatment for HIV and AIDS, you're seeing, and I've heard people in my practice say that they prefer get a diagnosis of HIV/AIDS than cancer, because they see cancer as very expensive, whereas the treatment for HIV is free. Now they've even made it easier. You can get an injection maybe every 3 months, and you still get free counseling and all of that. With cancer, it's expensive. It is time consuming. You are more than likely more than likely lose your job, or have to be boarded off after some time, depending on the advancement of your cancer, and all of these concerns are raised with a diagnosis like cancer. What are your thoughts on these debates or these arguments?
Okay, that's a huge debate over there. And so yes, one myth I would say about cancer is that cancer is a death sentence. No, cancer is not a death sentence when it is diagnosed earlier in the stages, and people take the treatment initially and not let it progress until it has spread to other parts of the body. Yes, if diagnosed early and if treated early, then the chances of survival definitely improves. And I have particularly seen patients with 25 years of follow-up, 30 years of follow-ups as well, who are in well and good health actually. So that depends on the stage where the person is diagnosed, and the treatment options which we have. And currently, with the advancements which we have in cancer treatments, so we are progressing with that, making sure that the patients have lesser side effects, and with that, as well as the treatments are more aggressive, so that the cancer cells are killed and the survival of the patient increases. So yes, there are many research things which are going on to improve on that. And that is one myth is, yes, definitely, that it is a death sentence. No, it is not if it is diagnosed early. That I would say.
I think
Calvin, I would like to make a small input on this as well, too, if you don't mind.
yes, certainly, Henry.
Yes, yes. So, a very interesting observation, the comment that you made as it relates to how people view HIV and how they view cancer. And suddenly it appears that cancer is now in that category as the most dangerous, right? There are some slight nuances in the mix here, I believe, that will probably give rise to that. HIV, to a very large extent, I mean, one can say that it is largely hinged to an individual's, activity, like your sexual activity and so on. Right. Cancer is nothing at all like that. All of us are at the risk of getting cancer. Yes, there are things that we can do to reduce the risk factors and so on. But everybody, it's a chance game when it comes to cancer. And I believe that because of that, there isn't the impetus, so to speak, for one to get themselves checked. Right, with on the HIV/AIDS side of it, I mean, there is that. If I know that I am very sexually active and you know, I'm somewhat lapse and careless in protection when I am engaging in sexual activity, there would be that impetus on my part to get myself tested. But with cancer, that is not so, right? And we are trying to get it infused into the psyche of the population that regular testing, frequent screening is very important when it comes to cancer because early detection is really the key. Most of the cancers that exist, most of them that we treat here at our center, they are curable, right? And curable meaning that if they are detected early and the patient presents reasonably early for treatment, we can apply the relevant treatment protocols, and those patients can live a normal, full life. Something else will kill them other than the cancer.
Mhm. Okay, and well said. We have a caller. Maybe that's for you. Let's hear from this caller. Good morning to you, caller. Thanks for calling. Good morning, caller. You on Health Vibes? We are hearing you, but not hearing you at the same time. Okay, we the person seemed to be having an outside conversation, but again, the numbers are 449-3095, 449-3096, 449-3097, 616-4257, and of course, if you want to join us from overseas, you can do so. That number is 305-432-9624. But Henry, though, I wanted to, as you're on. I think too the concern that comes with cancer is the cost.
Yes.
Who is going to help me? I do not have insurance. Yes, a government person may step in at some point, but in terms of continuous treatment, what will happen to me if I have exhausted the means that has been given to me? Or what happens then? And that is, many of us in the Eastern Caribbean, we still don't have, especially the average working person, still have not educated ourselves or have health insurance policies, and that is one of the issues. Let's take this caller before you answer. Good morning to you, caller. Thanks for calling.
Yes, hello, good morning.
Yes, good morning to you, sir.
Yes, I would ask the doctor, what are the symptoms of pancreas cancer?
Of what cancer?
Pancreatic.
Of pancreatic cancer. Okay, she mentioned it, but she can always answer the question again if you've caught us a bit late. But before she answers, let me just ask Henry to comment on that, and then afterwards, Dr. Reddy will answer the questions in terms of the signs and symptoms that you're asking about.
Yes, Carlton, that is very relevant. The cost issue, and the reality is what it is. I think that when we reach a stage where we're able to get the cost of the technologies significantly down, as was the case with HIV and so on, because you can probably recall that in the earlier days of HIV, I mean, the costs were prohibitive. And the continuing research and development and so on, we were able to bring those down. What is involved in cancer treatment are highly specialized equipment and so on. In some cases, we have gone robotics, etc. Massive amounts of investment that are imputed into these things. But in our present set of circumstances right now, we have a situation on our hand. The costs are prohibitive, but there are some things that we can do about it. And here is what I suggest, and it requires a national strategy, right? My advocacy is that, hey, let me spend $50 now every 3 or 4 months, as opposed to having to deal with 10,000 or 15,000 US dollars 5 years down the road. $50 now, meaning that I'm going to go get my prostate checked and do my PSA and all of that, etc. I will attend my doctor regularly. The culture of our people, which we have to break, is that we don't like to go to the doctor. We don't like to get ourselves checked out. A lot of times, a simple mammogram or something, pap smear, it might be $35. And the individual, the female, says, I don't have $35, right? And I am sure it comes down to prioritizations, right? When we get this message out and get people to understand, let us spend $2 today to avoid a headache of $200,000
Mhm.
5 years down the road, right?
Mhm. Mhm. And I would assume too that you would want to add to that the need for health insurance policies, especially among our young population that are working. If you have a steady job, you are comfortably appointed, that it's important to embark on a health insurance policy because you don't want to wait for as you may develop a chronic non-communicable disease to enroll because your chances are a bit slimmer. So while you're
Yes.
young, you can sacrifice again $100 a month
Of
for your
course,
premium,
yeah.
or $85. Sometimes it's even less than
Yes.
$100 a month for your premium. And I think that's another conversation that we need to have in the population.
Definitely. And
Yes.
I just wanted to comment too. Health insurance is not only for the eventuality of the disease, but just what Henry was mentioning, the screening,
Mhm.
all that, if you do have a health insurance
Yep.
coverage,
Mhm.
then you don't have to say, well, I don't have the money for the pap smear,
Mhm.
I don't have the money because the coverage will
Mhm.
cover even the screening test that you do. So
Yeah.
you can look at it from that angle as well.
Mhm.
And that's a very good point because our insurance companies in the region, they are all for preventative because we know the cost sharing as it relates to insurance and so on. When it comes to preventative, most of the insurance companies carry that burden all by themselves. You don't have a copay when it comes to preventative care, right? And it is part of them incentivizing the population, get yourself checked out because everybody wins. The individual wins with their good health. The insurance company wins with less monies to pay out for claims, right? In the event of a major medical, right? And so it is a very good strategy for us to do. But from an educational perspective, every citizen, every individual needs to understand that my life is my individual personal responsibility, right? We have social networks, safety nets, and so on, but there's only so much that government can do. In the case of Dominica, yes, our patients from Dominica, most of them, they are funded by the government through the Social Security scheme. But how many persons can that scheme carry on an annual basis? We ask ourselves that question, right? So, yes, we have to have educational programs to empower the people with knowledge, right? An ounce of prevention is better than a pound of cure, always.
Well said.
Yeah.
Dr. Reddy, the caller asked, maybe if you can just mention again.
Signs and
Um,
symptoms.
are you there?
Sure, not a problem.
Not
So the
hearing.
most common
Okay.
symptoms which we would
The
see
signs and symptoms. Okay, I'm hearing again. The
symptoms
signs and symptoms associated with pancreatic cancer.
Yes. So those would include jaundice, one, and the second one being fatigue or tiredness, and weight loss, new onset or worsening of the diabetes, and if there is dark colored urine, pain in your abdomen with history of pancreatitis or history of family history of pancreatic cancers, and there might be large amount of fat in the stool as well when they pass because of all these enzyme changes which they have, and yes, sometimes they might feel the skin might be really itchy because of all the jaundice and other things. These are the most common signs and symptoms for pancreatic cancer.
And again, caller, I do hope that you would have picked up the signs and symptoms that the doctor narrated just a while ago. It is now 11:29. We have to wrap up. Doctor, I'm going to give the first opportunity to you to just summarize and maybe give some last parting words and of encouragement to our populace and all our listeners who are listening.
So yes, in general, as an oncologist, I would say in regards to the cancers, rather than taking it so light or not getting checked regularly or not getting themselves screened wouldn't help much. And I would recommend everyone to get themselves checked regularly and get themselves screened, not in particular to the pancreatic cancers or prostate or whatever, but get themselves regularly checked and make sure that they are in good health and have healthy diet and cut off from all the habits which they have and practice healthy lifestyle, so which would in turn have some preventive effect on the cancers. And definitely if they have a family history of cancers, I would recommend them to get themselves screened regularly. And if it is diagnosed in early stages, please do not get it prolonged and get your treatment started as soon as possible. And if you need any help in terms of diagnosis or coping up with the diagnosis or for further management or anything, always the doctors would be available to guide you through that, so that you would be doing well with your further management. And I'm really thankful for this opportunity which was given by you.
You're welcome, Doctor. So much. You're very welcome. Mr. Hazel.
Yes, Carlton, always a pleasure. And I just want the listening audience to know that we here at the Cancer Center East Caribbean, we are the center for the OECS, right? So we would rather have a very healthy population than having a lot of patients here to treat, right? And that is why we are investing so much in public education. We do a lot of community initiatives as well too. The health of the nation is the wealth of the nation. And I just want to leave that with our listening audience. Let us take individual personal responsibility and be good citizens.
Thank you so much, team. Thank you so much. And we are so happy that you've joined us for yet another episode of Health Vibes. This morning, we focused on pancreatic cancer. We learned a lot about the disease, the prognosis, the diagnosis, the signs and symptoms, and the treatments and everything else that was associated with it. Next week, as we did say, we'll be talking about HIV/AIDS with Mr. Lester Guy. As you know, tomorrow is World AIDS Day. It's a very significant day. And again, HIV and AIDS is still around. It has not gone to sleep. It has not been extinct. And so we want you to be cautious. We still want you to be to protect yourself. And as always, we've always said to you, your health is indeed your greatest resource. Preserve it. Have a good morning, everybody, and do take care. Bye-bye.
Bye.
Who say health cannot have vibes? Well, Jolly's Pharmacy is proving you otherwise. With Health Vibes, every Wednesday morning on Q95 from 10 a.m. to 11:30. Health Vibes, education, information, and a bit of humor. And not forgetting lots of vibes. Hosted by Carlton Langdo with co-hosts Jacinta Fagan-Defo and Trudy Kristen. Jolly's Pharmacy is bringing health and vibes together every Wednesday, so be sure to tune in. Health Vibes every Wednesday on Q95 from 10 a.m. to 11:30. Jolly's Pharmacy, leading the way in healthcare.
Easy Rock 95.1. More rock, less talk while you work. The latest soft rock, hit after hit. Tune into Easy Rock 95.1, the best mid-morning show in the right here on Q95.